And happy Saturday evening to you. This is Dr. Barry Gritz, also known as Houston's dancing psychiatrist here. We're going to be talking about major depressive disorder in adults. And what I'm going to be doing later within the next 24 to 48 hours is I said that I was going to post a dance move at the end of each lecture that I do, each podcast that I do. What I'm actually going to do is do that after, so that way it flows naturally. But I am going to post at least one move because this is part of dancing as a source of wellness. We are definitely going to be showing some easy moves. The whole idea that I'm going to be doing is moves that have 8 counts. By that I mean when you listen to music and each song you listen to is broken down into 8 counts. So the moves I'm going to show you can be used pretty much for any music, and you can have fun with it because that's what it's all about. Getting your body moving, because one of the things you're going to hear me say a lot is motion is lotion for your body. And if you're moving, you're grooving. That's going to be the hallmark of what I'm going to continue to bring home with y'all. And that's what we're going to be talking about when we do the dance portions. But today we're going to be talking about adult major depressive disorder, because there's a lot of misconceptions out there about what it means. There's misconceptions out there that people say, oh, just get over stuff. Don't tell yourself you're not going to be depressed and you won't be depressed. And it's just not that simple. Now, what we're going to be talking about is there's lots of things you can do to help your mood outside of medication. But we are certainly going to talk about the fact that medications for a lot of people are an important piece of the puzzle, and they are something that do need to be talked about for the appropriate patient. But let's first delve into what major depressive disorder is. Let's talk about some statistics about major depressive disorder before we do anything else. Major depressive disorder, the second leading cause of disability after lower back pain. You know how prevalent lower back pain is. That shows you how prevalent, how existent in the worldwide population depression is. And it's a major cause of disability, and it interferes with your ability to interact in a social, interpersonal, and occupational life. So that affects you interpersonally, occupationally, and remember, if it affects you, it also affects your family. So the global effects of this are huge. What about the prevalence rate? They say that the statistics are about 36% of females will have an episode of depression at some point in their life, and 20-some% of men. Now, that works out to be almost a 2-to-1 ratio of female to men. Also, women are 3 times more likely to attempt suicide than men. Men are 3 to 4 times more likely to unfortunately complete suicide. One of the reasons we think that is that men often use more aggressive weapons in their suicide attempts, and that is probably one thing that goes on. But one of the things I want you to take home from all these podcasts that we do, are that depression is not your fault. It is not a fault. You don't blame yourself if you have hypothyroid disease, but people blame themselves for having depression. They feel weak, like I should be able to just pull myself up on my bootstraps and not be depressed. It's just not that simple. Once again, we're going to be talking about non-drug options that are available to help depression and lifestyle changes, because that's going to be a whole crux of what we talk about here. What kind of lifestyle things can you do to also improve your mood and to improve your life? Because the whole concept of this podcast is really about wellness, socially, interpersonally, occupation, being your best, living your best life. So, that being said, do not let others just tell you to pull yourself up by your bootstraps, and don't feel bad, because people will try to guilt you into feeling bad about having depression. You already feel bad about having depression. You don't need their guilt. Very famous pastor down the block, my office is very conveniently located to an awesome pastor who's down the block. One of the many things that I've heard him say in his podcast is people are always trying to put garbage in our garbage can. But if you keep your lid closed, they don't have the ability to do so. Or another thing that he talks about that I love is joy. People say, oh, this person took my joy away. His response and my response is they can only take away what you allow them to take away. You have to give up your joy to them in order for them to have it. They can't take something that you don't choose to give to them. So keep that in mind too. People can do what they're going to do, but you have how it affects you. That's on you. You cannot stop people from doing what they're going to do, but you can stop how you let what people do affect you. And we're going to be talking about that a lot. That's a theme that I'm going to repeat a lot throughout all the podcasts that we're going to do. Okay, so now let's get into major depressive disorder. We want to talk about what kind of symptoms are suggestive of major depressive disorder. Symptoms of major depressive disorder are the following. We used the mnemonic SIGECAPS. SIGECAPS. What does that stand for? Good question. I'm glad y'all asked. S stands for sleep, meaning that patients with major depressive disorder frequently have problems with sleep. They can have what's called initial insomnia, which is problems falling asleep. They could have problems with middle insomnia, which is problems staying asleep, or they could have terminal insomnia. Terminal insomnia refers to the fact that the patient wakes up 2, 3, 4 in the morning and can't get back to sleep. So that's insomnia. We said SIG. I stands for interest. Patients with major depressive disorder frequently have I, which stands for lack of interest or anhedonia, lack of joy or pleasure in their life, or depressed mood. So lack of joy or pleasure or depressed mood. G stands for guilt. Patients sometimes have feelings of guilt, hopelessness, helplessness, worthlessness. E is energy. Patients with depression frequently feel tired and fatigued a lot. C is concentration. Patients frequently will have difficulty with thinking, concentrating. I want you all to think of depression as a cognitive illness. It really does affect our cognition, our ability to think, our reason, and this affects us, once again, in our workplace. This affects us in our interpersonal life. A is appetite. Depressed patients frequently have impairment in depression in their appetite, but meaning they could have decreased appetite. But we sometimes see people that have actually increased appetite. And unfortunately, when patients have increased appetite during depression, they frequently have problems with craving the foods that are not good. Meaning, and when I say not good, meaning not that they don't taste good, but foods that are not good for you. We're going to be talking a lot about, because this is a wellness show, we're going to be talking about diet and an anti-inflammatory diet and a healthy microbiome. We're going to be talking about that a lot, repeated that throughout my podcast. But really what we're talking about is depressed patients frequently crave foods that's not good for them. Fried foods, processed foods, and we have a lot of that. So they frequently, and why do they do that? Well, one of the things that we think goes on is that when you eat something that's processed fast food, delicious tasting, but fast food, you get a rush, an immediate release of dopamine. Dopamine feels like drive, energy, motivation. It feels temporarily good. But what happens is that crashes quickly. That has you going back to get more of that food, which once again is not a good cycle. So we see that a lot, impairment in appetite. Usually decreased appetite, and patients with depression frequently lose weight, but they could actually have increased appetite, craving carbohydrates, craving sweets, craving processed or fast foods, and as a result, they actually could gain weight. And we talk about psychomotor activity, that's the P, when I said SIGECAPS. The P is psychomotoric activity. That refers to the fact that the depressed patient frequently is showing decreased range of motion and decreased activity, i.e. the opposite of what I try to encourage if y'all are in my Zumba or Aqua Zumba class. And S is suicide, recurrent thoughts of death. And suicidal ideation can be what we call passive. Passive suicidal ideation refers to the fact that patients may have feelings like, if something happened to me, I really wouldn't care, but I don't have active suicidal plans. While active suicidal ideation is the patient has active suicidal thoughts and or plans. Okay. What goes on with depression? Well, we think that it can be due to impairment in certain neurotransmitters, serotonin, norepinephrine, or dopamine. When I describe to patients what impairments in serotonin look like, and what I want to talk with you all about, depressed symptoms due to serotonin imbalance frequently manifest in this manner. Symptoms of depressed mood, plus feeling angry, irritable, obsessional, ruminating, thinking, worrying, ruminating, anger, irritability. And that's why when we frequently use medications that increase serotonin, what do we get? We actually get patients feel calmer, less anxious. Patients will say that stuff that used to bother them doesn't really bother them anymore. Next thing is norepinephrine. Norepinephrine or noradrenaline is a neurotransmitter involved in symptoms of depression, but it's also involved in symptoms of lethargy or alertness. It's also involved in chronic pain, and that's why some of the antidepressants that increase norepinephrine also are used for pain relief, because norepinephrine is involved in what we call the descending spinal pathway of pain, and that's why norepinephrine enhancing antidepressants can have, in addition to an antidepressant or anti-anxiety property, they could actually have a pain relieving property. And then we talk about dopamine. Dopamine is symptoms of depression plus drive, energy, motivation, joy, pleasure, desire. Those are the kind of things we talk about with that. There are also neurotransmitters that are being talked about and that we do think are relevant to depression. We talk now about glutamate, and some of the newer drugs out there actually are involved in glutamate, i.e. they work on glutamate and enhancing or blocking glutamate receptors. Glutamate is what we call an excitotoxic, meaning it's an excitatory chemical. So a lot of the antidepressants that actually work on blockade of glutamate receptors, and we'll talk more about that. Next, we're going to be talking about what are some of the non-pharmacologic options. What are some of the non-drug therapy options that you can do that I recommend for treatment of depression? Exercise. You guys know the Dancing Psychiatrist. I teach multiple classes a week. I teach Tuesday nights, land Zumba on land. I teach Friday mornings, Aqua Zumba. Friday night, land Zumba. Saturday mornings, Aqua Zumba. Sunday mornings, land Zumba. And in addition to that, something that I've been negligent about, and it's very important because I'm getting up there in years, is also doing some exercise where you actually are building muscle mass. With everybody being, or a lot of people being on GLPs, one of the things that happens with the GLPs is while you might lose weight, you can also lose muscle mass. As we get older, we also lose muscle mass. I don't have the muscle mass I had when I was in my 20s or 30s when I was really into lifting weights. But I do, and I'm getting the aerobics with Zumba. Zumba's got my heart rate in a good place, but I need to be adding back that weight training, that muscle mass. So weight training, aerobics, really good combination. Exercise, adequate sleep. Sleep is a nourishing, restorative thing for the body, and we really need to work on that. And we'll have a separate podcast where we just talk about sleep. Diet. You're going to hear me talk a lot about an anti-inflammatory diet. I'm just going to throw out a little bit of information in that regard now. I want you to think of your gut. Your gut is very involved in your immune system. 70 to 80% of your immune system is located in your gut. Having a healthy microbiome is very important to both your physical and your mental health. I'll give you an example. We have billions of bacteria, and we also have viruses, fungi in our gut. When you eat a healthy diet, meaning more of what I refer to as an anti-inflammatory diet, which is a diet which is more, you may think of like more of a Mediterranean diet. So it's high in vegetables and legumes and can have some animal protein, but that's not the majority of it. That's in contrast to the SAD diet, which is really more of the standard American diet, which is high in processed foods, fats, animal products, milk, dairy, etc. So we're talking about that. We also want to talk about psychotherapy. I do refer people to psychotherapy and to psychotherapists. Why is that? Because the medications that I prescribe as a psychiatrist, they only work for as long as you take the medicine. But the changes in your brain wiring and the changes in your brain chemistry that you bring about through psychotherapy and the skills that you learn in psychotherapy, that's your gift to have for life. So I really try to encourage patients to see a therapist and learn those skills too. So really, and psychotherapy can be cognitive behavioral therapy, which looks at distorted ways and ideas that a patient has and approaches life with some distortions of what's really going on in their life, or maybe distortions about how to solve their problems, versus interpersonal therapy versus psychodynamic. We could talk more about that in depth at a later date. So what we really want to do is I want to kind of conclude by talking about some general family of medicines, and then in another podcast we'll break down the medications and talk about them more in depth. But to talk about the general family of medicines we talk about with depression is we talk about, once again, the SSRIs, which stands for selective serotonin reuptake inhibitors. These are drugs you've heard of, like Prozac, Zoloft, Lexapro. What do? Thinking about what I said earlier, they work on serotonin, so they help with symptoms of depression, plus anger, irritability, obsessionality, rumination, thinking, rumination, worrying. When patients are being appropriately treated with the antidepressant, one of the things that they talk about is they talk about that they feel calmer, they're better able to let stuff go and not sweat the small stuff. The SNRIs are drugs like Effexor and Cymbalta. Those are drugs that can work on serotonin and norepinephrine, so in addition to helping with depression, they could potentially help with chronic pain syndromes, with pain. And then we have a norepinephrine dopamine drug like Wellbutrin, which works to increase norepinephrine and dopamine. Once again, dopamine involved in drive, energy, motivation. Then we also have a group of medicines referred to as the norepinephrine and serotonin specific antidepressants. These are drugs like Remeron, which we'll talk about at a later date, can be useful in a certain subset of people, but there are limitations. Then we have newer medicines, which are referred to as the glutaminergic agents. And these glutaminergic agents are medications that work on the glutamate system. And these are drugs you may have heard of, like Auvelity, or you may have heard of Spravato and ketamine therapy. These work on glutamate. Then we have the augmentative agents, meaning often we have a patient on an antidepressant or an antidepressant regimen, and that regimen isn't enough. It isn't totally getting resolution of the depressive symptoms. And then we add medications that are FDA approved for depression, for depression augmentation, meaning a patient who's an adult who's on an antidepressant, certain medications can be useful when added to the antidepressant. And these are drugs you may have heard of, like Vraylar, Rexulti, Caplyta, Abilify, Seroquel. And then there are mood stabilizers like lithium that we also sometimes use to augment antidepressants. And while I don't do it very often, thyroid hormone can sometimes be a depression augmenter. And then there's some alternative treatments like RTMS, which is a type of transcranial magnetic stimulation therapy. Ketamine, which can be IV or intranasal. The intranasal is known as Spravato. And then ECT. So at some point, we're going to talk more about the medications. In fact, I think what we'll do is in our next podcast, we'll break down those medications and talk a little bit more about them, realizing that what I talk about here today is only meant to be a supplement for what you do with your clinician, whether it's a nurse practitioner, PA, or your psychiatrist, or your general medical doctor, meaning your PCP. What I'm trying to do is give y'all information that y'all can then use and bring into your treatment process. And I really believe that knowledge is power. I really want you guys to use the information that we talk about to go talk with your clinician, and also to don't forget to incorporate those other non-pharmacologic options so you can be the best that you can be, you can feel the best way you can feel, you can attack health mentally and physically from a global standpoint, because that's really going to be what we're trying to attack here today, and the theme that I'm going to continue to try to bring home here. But once again, I want y'all to have discussions with your clinician. I also want y'all to invite y'all to send me questions that y'all have, topics that y'all have at Houston'sDancingPsychiatrist.com. That is where you can ask questions. Now, realize again that I'm not going to be looking at those emails every day. So if it's a medical question that you need urgently answered, that's also a reason to go speak with your clinician about. Also, once again, substituting that anything I say here is never a substitute for talking with your clinician and discussing your treatment plan with your clinician. This is about augmenting your knowledge of that so you guys can be the best y'all can be in y'all everyday life. I'm going to be posting within the next 24 or 48 hours your dance tip. I think what we're going to do is we're going to do a little Bollywood number, which is a little 8 count on a Bollywood song. What I'll do is I'll show you the step, and then what I'll do is play a little music to it, and making sure that we keep it just short step that you guys can practice, and then at a party you can impress. So once again, this is Houston's dancing psychiatrist, Dr. Barry Gritz, talking to y'all about major depressive disorder. Next topic is going to be, we're going to be breaking down the medications we talked about here today, talking with them a little bit more in depth, realizing that no one medication fits every patient. These are all tools in your tool belt. With that, I'm going to sign off and wish y'all an amazing rest of y'all's weekend. Dr. Barry Gritz, the dancing psychiatrist. Y'all have a good one.